Can we just very briefly, Horst, what do you think? You know, are you convinced that ICE is adding anything to PVL judgment?
We don't use it for cost reasons because we want to keep our tax as low as possible. And I must say, we also don't use TE anymore. So it's if we just look at the angiogram, if there's a small leak, then we leave it. So it does not have any consequences.
Any other thought?
I think it depends on the experience of the use of the eyes. What I mean is even though they try to make a good image in the eyes, but does not have a much experience. You know, for the treatment of the structural heart disease for the appendage occlusion and or ASD or PFO, they have the operator have the large number of the experience of eyes. They manipulate the catheter is very fluently. So when you have more experience of that, maybe at that time.
Yeah, maybe. Okay.
Dr. Ahn?
Yes, good morning. Good morning, Dr. Hong.
Okay.
Yes, this is the second live demonstration. Good morning, Eberhard. Good morning, SJ, and good morning, Dr. Hong. I'd like to introduce my team. This is Dr. Go and Dr. Cho. Always EVA group helped me for a long time, but today, Dr. Go, I'm doing the procedure with Dr. Go. Okay, Dr. Go,
yes.
Please introduce the second live demonstration case.
Okay, sure. This patient is 81 years old, female, present to our hospital with syncope, and she had a history of hypertension. And also she got the history of aneurysm and the clipping operation in 2009. And next. And again, she got the hypertension, and the STS score is a 2.4, so belonging to the low-risk profile. And next. Echo finding shows the ejection fraction is well preserved, and the aortic valve area is 0.7, mean pressure gradient at 51, and also she got the mild AR on the echocardiography. CAG shows just only mild stenosis at the proximal LAD. And next. EKG shows a normal sinus rhythm. And next. Chest X-ray is also normal. And this is the annulus measurement. And this patient annulus perimeter is 17.1.4, and short lung diameter is 21.2 and 24.0. Annulus area is 402. And next. This is a measurement of a sinus valsalva and the SC junction. The most important variable in this slide is the ratio between the sinus and the annulus. This patient have a 1.77, and the mean value of the all cases what we have done so far is 1.83. So this patient have a relatively smaller sinus valsalva, and in SC junction, the ratio is 1.32, average ratio is 1.49. So this patient, the aortic root is relatively smaller than the average. And next. LVOT, the ratio is also 0.83, mean ratio is 0.95. So this patient also got a relatively smaller LVOT. And next. Calcium amount is quite less. Total calcium amount is just 93. And next. And next. Coronary height is more than 10. And next. Peripheral is quite large enough for the transfemoral approach. And next. Today, we have chosen the Everett Pro. And usually our target percent oversizing in the 20 to 30% oversizing compared to the perimeter oversize. And today we have chosen 29. That means 129.5% oversizing. And next. Okay, Professor Ahn, please.
Yeah. Do you have any comment? Actually, this patient is low-risk profile and older age. Do you have any comment on the TAVR indication on this patient or other questions on this patient?
Is there any reason for the selection of the Evolut Pro in this patient?
Dr. Go, do you?
Yes, this patient have annulus area is 402, so 402 is a very borderline between the 23 and the 26 in Sapien 3. So when we choose a 23 Sapien 3, it's quite small, and when we choose a 26 Sapien 3, it's quite big. So that's why we have chosen the able to flow for the precise sizing.
Another reason is the calcification is very rare.
Yes.
The calcium volume is only 80.
Yes.
So the anchoring is, we believe the anchoring is better in the self-expandable device
Yes,
than the balloon
retrievable,
expandable
yeah.
device. So we selected the self-expandable device rather than balloon expandable device.
28% oversizing with Evolut Pro 29 millimeter valve. Such a kind of oversizing may be tightly associated with AV block, because you have to try to implantation as high as possible.
Yes,
Yes.
I will try. So the
Can-
base, yeah, keep
No,
going.
I hold myself back. Any other comments from the panel members as far as the selection of the valves concerned? I always ask James, you know, apart from the S3, what would you take here?
If I choose A3. The reason is the coronary artery is not that high, actually, particularly on the right side. There's a look on the CT is pretty low, actually. I look at the CT is long excess. So, and patient have a mild coronary disease, and also you can see the calcification in the coronary arteries, the circumflex and the AAD. So I thought that Sapien 3 probably will be good for the reintervention or in the future. That's why I will probably choose a Sapien 3. The calcium is enough to anchor in both valves.
Yeah, Paul, any thoughts?
I think both are reasonable, and
I'm sorry?
both valves will be okay. I think Evolut Pro is a good choice here.
Well, if I may add, you know, if I had a choice between the two cases, I would probably switch the valves around. I would probably take the Evolut on the previous case and the Sapien on this case, because I agree. You know, look at the takeoff of the left. The sinuses are small, so it's interesting. I mean, obviously, it's physician's discretion, and I'm sure he's going to be, as far as I'm concerned, Jung-Min is probably one of the best operators for Evolut, so I'm sure he's going to be successful. But since we are having different choices now, not only in Korea, any other thoughts on any of the other valves? I know they are not available in Korea, but I'm sure many of you have seen other valve types. Anything that would attract you in this particular case? To be very honest, in this case, looking at the other options with very, very minimal calcium, there would actually be a good case for Symetis. Anyway, since you have decided and you was asked us the discussion, you know, we discussed this a little bit. Good, go ahead.
Yeah, okay. So the calcification is very rare, so we are doing without pre-dilatation, and I'm using the inline sheath. So can you show us? Next, please. So we insert wire. We already insert wire.
You already have done the case,
yes,
right?
Yeah. Insert wire, not finished. Not yet. Insert wire, and next, the inspection. So I'd like to start from
Good
here.
loading.
Yeah, good loading, and insert wire, supply wire, and then
wire 좋습니다.
very smoothly. Okay.
I think probably it's a good thing, you know, to pre-dilate with little calcium, right?
Yeah. Test, please. This is implantation view. Okay. I like to start the deployment.
Regarding predilation, Eberhard, you are really a front runner to skip the predilation. So I really agree with your philosophy, because now we have some interest data. the actual symptomatic stroke incidence is higher in bicuspid AS than tricuspid.
Slow.
Interesting.
I think it is associated with more touch. So we always perform pre-dilation in bicuspid AS. That may be
Test it,
associated with
please.
higher
Yeah.
chance of stroke.
Yeah,
So
that's
Okay.
this guy skip. I try to skip pre-dilation.
yeah.
It's pretty low, isn't it?
괜찮습니다. Slowly.
Up deflation.
Now it's too high.
Did anybody say?
Not too much
Did
calcium.
anybody say pretty low?
Some difficulty
panel?
anchoring.
So we prefer to pace with 120 or something like that during this phase. Makes it a little bit more stable, I think.
Okay. Inflation.
Yep.
Deployment. Test please. Okay.
천천히 가겠습니다.
네. Stop please.
Yes.
Now more slowly, more
Yeah.
slowly.
Yes.
Stop.
Yep.
Inflation. Deployment.
Yes. Slowly.
Stop.
Yep.
I would do rapid pacing.
Yes, it's time to be the left ventricular pacing, maybe 100 or 120
More.
during the deployment.
갈까요?
What is the
Okay.
blood pressure?
Blood pressure is 90, 100.
The,
Mhm.
what about the more is a fixed LV wire,
Yeah.
and you can manipulate this more.
Okay,
I
slowly.
prefer my last
Slowly.
movement before I start deploying to
Right.
be a forward movement
Deployment.
or pushing instead of pulling. I don't know whether the other operator have the same experience, because if the last movement was try to pulling the valve up and then you start deploying,
Deployment.
Yep.
Mm.
the pop-up
Stop.
happen more frequently.
There are two factors for such kind of slip lead. The first one is less calcification. The second one is LVOT diameter is actually narrower than the annulus.
Stop. Deployment. Deployment. Recapture.
More. Okay, good.
Okay.
Right.
Deploy.
Yep. 가겠습니다.
This is for rapid pacing.
Deploy.
Yes.
It's time to do pacing.
Okay. Deploy.
Yep. 천천히 가겠습니다.
And I
Stop,
would,
stop.
paradoxically, I would start higher.
Okay.
Because now that valve is diving in, they pull,
Yep.
and
Deploy.
that's
Yep.
Deploy.
Yep.
Deploy.
Yep.
Deploy.
Yep.
Deploy.
Yep.
It's the when before the valve gets the contact to the annulus. I think I really, in this case, because there's not much anchoring, LVOT is small. Probably it's a good idea to pace, because you can see it's always after PVC when the valve's being blown up. So probably I would
Pacing
also use
100.
pacing. But I know Jung-Min is cool. He's going to be doing it.
Deflation.
Okay.
Deployment.
Yep.
Deploy.
You need a more rapid ventricular pacing,
Okay.
more than
120.
120 or
Okay.
more, and hold the system conformly, very strongly hold it.
and start higher. Now it's again too deep, and then they pull.
Test. Okay. Deploy.
Yep.
It's too deep.
천천히 가겠습니다.
Stop.
Yep.
Deploy.
But it's always so easy to sit here, huh? And comment.
Stop. Stop. Deploy. Deploy.
Deploy.
Keep going.
Yep. 피어라토로 들어옵니다.
Keep going. Keep
Keep
going with
going.
pacing.
Keep going. Keep going.
예.
Stop.
Until the blood pressure is up.
Pacing.
페이싱 업.
Off 하세요.
Jung-Min, I think I would reduce pacing, not stop it.
Stop. Pacing stop.
Okay.
Okay.
Okay, let's check it.
Test.
Angiogram?
Looks good.
Okay.
Yeah.
Yeah, that looks good.
I think it's good. Good.
Yes.
Yes, I think. I like to deploy further. Keep going.
Yes.
Still okay.
Slowly,
When you
slowly.
release it, very slowly,
Slowly.
more slowly.
Stop. Lay over.
Yes.
Okay.
Good.
Not released.
One more.
More.
Yes.
Okay.
Okay.
테르모 주세요.
I like to remove the system like this.
Be careful. All right.
네, 연결하겠습니다.
네.
네, 됐습니다.
와이어
Evolut
주세요.
Pro is definitely difficult, more difficult than Sapien.
아니, 스트레이트 말고.
Sapien is very simple, easy. Evolut Pro is really requires know-how and experience. Yeah, 29.
다시 하겠습니다.
네.
This is change is just LBBB, not AB block.
Can you see the
에코 right now?
echo, please?
Are we seeing another ice?
No, just
No, I
please.
right now. Just the strength.
1 minute
echo.
fluoro on your
Would you
hand
say?
is the maximum
Check,
dose which is allowed for the
Steve,
entire year.
All right. In the
Steve,
practical point of view, so we measure the
테프로나이어 주세요.
CT algorithm in terms of ST junction ratio, sinus ratio. In particular, this case is relatively small ST junction. To be honest, we prefer Sapien. The meaning is after long-term follow-up, just James mentioned about the coronary access concern. The ST junction is relatively narrow. Is impact of for particular this case low calcium, so we have to choose a little bit bigger perimeter ratio, etc. Issue is coronary access is very difficult. If the sinus is big, I think it's okay in even in the self-expanding. So personally, Sapien would be better. However, we have to separate and wait for Sapien and Evolut.
So SJ, what is your, giving all your the formulas and approaches, what's your actual pacemaker rate of the Evolut platform?
Less than currently less than 10%.
How much?
Less than 10, 6
I
and
see.
7%. Much better than the Cobalt, but however still quite high.
No PVL right now.
What the PVL?
Yeah, no PVL.
No PVL.
Trace PVL right now.
Can you show the
Dr. Kim,
image?
I have
right
one
now.
question to about the image of the echo.
Yeah.
What is the opinion of the lower margin of the Evolut Pro? Is that acceptable? is there any interference of the lower margin of the Evolut Pro for the mitral valve motion?
But I think there is no impingement of anterior mitral valve replant right now. It seems to be slightly deep, more than usual. But no impingement of mitral valve right now. Dr. Hong, do you agree the echo finding?
Yes. I have some
What are
question.
you agreeing on?
What I mean is that on the fluoroscopic image, the Evolut is a little bit looks like deeper. But
Yeah, I
compared
agree.
to the echocardiographic image, it's maybe reasonable. So it's some difference between the fluoroscopic image and the echocardiographic image.
I think clinically we very seldomly see that kind of TAVR valve interacting with the mitral valve leaflet.
No interference of mitral leaflet right now.
Okay. Can
Yes, low margin is
check
okay.
the
Dr. Kim,
autograph?
Yeah.
we can see some paravalvular leak and
Oh,
there's
not
some
trace
gap.
power looking right now. Do you want to move
It's
to
not
apical
trace,
imaging?
I think it's more than mild.
Okay.
Oh,
Ready?
I don't think so.
Ready?
Just the central area mainly.
Audio view, please.
좀 편히 가겠습니다.
Ready?
I think this procedure is quite successful. The reason why there is the failure of the trial of the pump. So last time the valve should be deployed. So even though a little bit deeper, but I think it's clinically is quite successful.
Some mild
I
paravalvular
think it's
leakage.
okay. I think it's.
There is some mild
I think
paravalvular
result
leakage.
is
but,
good.
Just
yeah,
mild.
yeah,
Yeah.
Diastolic pressure is good.
yeah.
Your echo is good.
Yeah.
Agree.
So I like to finish my procedure, and then I like to remove
Very
all the
nice.
Excellent job.
Keep going. 와이어 캡하고. 시스 넣어주세요.
되겠습니다.
네.
Okay, excellent job, Dr. Ahn.
Yeah. Thank you.
Beautiful, as always.
We will move to the featured lecture.
I notice
thank
I'm
you.
getting older. I'm not on your side anymore. CSJ, that's destiny.
How long do you leave the pacemaker?
Pacing of patient rhythm is the sinus rhythm, no block. Yeah.
How long do you maintain the pacing catheter?
So at the SAPIEN 3, for the case of SAPIEN 3, on the table, no block, we usually remove the pacemaker, temporary pacemaker, but for the self-expandable device, at least one night, we kept the temporary pacemaker at the ICU.
Okay, excellent job. We will move to the lecture.
Thank you, Dr. Hong.
Okay.
Good
Thank
job.
you very much.